So the last presentation is from Nuala, Kane, and I made a mistake earlier that it's actually Nuala who has the Tom Palmer Award. Nuala is due to submit in May and has just come back from an NIH travelling fellowship, which must have been very interesting. And has a consultant post now in Dublin, and we wish her lots of luck with that. Nuala, would you go ahead and do your presentation?
Thanks very much, Claire. Can I just check that people can see my slides okay?
Yes, that looks fine.
I'm also on a Mac, so I was also panicking when Camilla was panicking. Thank you. Yeah, so this was my final Scholars Day. So my project is working on difficult and contested capacity assessments, and so my interest in this area really came from my clinical experience. Particularly in liaison psychiatry, but I think across mental health, we do assess capacity more and more, and sometimes it can be tricky. And I suppose I was really interested in getting to the bottom of why it's tricky sometimes, and what can we do to help clinicians who are approaching these difficult capacity assessments. And yeah, as Claire mentioned, so I was awarded the Tom Palmer MD Res scholarship in 2018. So just to give a sort of overview, so my work is really focusing on how capacity assessments happen in practice. And in England and Wales, the Mental Capacity Act is the legal framework which sort of governs how we do capacity assessments. And I'm interested in capacity assessments in practice in different types of practice. So you'll see on the top left there's a picture of the High Court. So the Court of Protection, including sort of High Court judges, oversee capacity assessments when they're sort of escalated to court level. So I was interested in court practice, but also in hospital practice. So in the general hospital setting as well, where capacity assessments are frequently carried out in relation to capacity to consent to medical treatment or discharge decisions or social care, also in the context of discharge. So again, I'm interested in sort of how, we have the black letter of the law, but how is this actually applied? How are the capacity criteria applied, and what are sort of those who are assessing capacity actually doing in real world settings? And just sort of, or maybe I should briefly say just an overview. So today, so I've done 3 studies as part of this, as part of my MD Res. The first 2 studies were the court studies, and the third study, which I'm going to speak more about today, was a study in relation to the medical setting. So just briefly, the 2 court studies, which I've presented on previous Scholars' Day. So the first one was looking at disputed cases in the Court of Protection, so looking at what really are the characteristics of cases where there's disagreement about capacity and how the judge resolves those cases. And then the second court study was looking at a large body of judgments from the Court of Protection, and looking at how judges and expert witnesses, who are often psychiatrists, how they actually justify their capacity findings, and making a sort of typology of the kind of reasons that are given, or the kind of decision-making abilities that are cited by the judges and by the experts. But the third study, which I'm going to talk about today, is an interview study. And in this study, I interviewed liaison psychiatrists who practice in the general hospital and are often seen as the sort of capacity experts. So if a surgeon, for example, is really struggling to figure out whether a person has capacity to consent to surgery, they might ask the liaison psychiatrist for a second opinion. And so just very, very briefly, because I know not everyone is familiar with the capacity law, the Mental Capacity Act has a definition of what it means to lack capacity. And it says that a person lacks capacity in relation to a matter. So it's always a specific decision or specific matter. If at the specific time, the material time, he's unable to make a decision for himself because of an impairment or a disturbance in the functioning of the mind or brain. And this idea about being unable to make a decision is further sort of specified as an inability to understand, retain, use or weigh relevant information, or an inability to communicate that decision. So that's sort of what the practitioners are putting into practice essentially when they make an assessment of capacity. So to talk about the interview study, so this, I sort of wanted to focus on the findings or the results. So I've just I'm going to just speak very briefly on the kind of protocol that we used. But we wanted to speak with liaison psychiatrists because we know that they're the kind of these capacity experts in the general hospital. And sort of the background of this was, we know sort of clinically that sometimes capacity assessments can be tricky, and this is talked about sort of in the theoretical capacity literature quite a lot. So philosophers and lawyers are fascinated by sort of capacity assessments and how they can be difficult, but there's very limited sort of research studies looking at what's actually difficult in practice. This is just 2 studies based in Switzerland from a single sort of interview study there, and they picked up that sometimes with sort of more complex medical or psychiatric conditions can be tricky, sometimes if cognitive impairment is fluctuating, for example, or if they're really high risk decisions like sort of a life-threatening medical decision, or where it looks like somebody might, where the decision is about somebody moving to a new living environment, to a nursing home, for example, that those can be particularly difficult. But we don't have any information on how people actually deal with those difficulties in practice, how they resolve those cases. So the aim in my study was to describe how these experienced liaison psychiatrists, to describe their sort of self-identified hard capacity cases, so the cases they thought were tricky, and how to resolve them in practice. And the way I did this was to interview 26 liaison psychiatrists across 3 countries. And the idea was that then the difficulties wouldn't be just specific to legislation, but they'd be really about sort of the difficult cases in practice rather than sort of vagaries of the law. And then I analysed these using thematic analysis. And I've picked out, so these are the 4 main themes that came from this analysis of the interviews. So the first was where the psychiatrist had difficulty whether the person's decision was really their own, whether it was their sort of true decision, or whether it was driven by some kind of mental illness. The second was, and I'll give examples of these, the second was where they had trouble in applying an ethical principle, so a principle like autonomy or wanting to promote somebody's welfare. The third was where they felt there was difficulty in avoiding personal bias or professional bias. And the fourth where there was some kind of procedural difficulty, so difficulty in actually carrying out the assessment itself. And I'm going to give sort of one example of each of these, but I'm again the paper is shortly to be submitted, so I'm very happy to circulate if anybody's interested or to answer any further questions about the results. So the first one, so the difficulty in determining whether the decision is the patient's own or driven by illness. And one example here was sort of hard cases which came up where the psychiatrist was really struggling to figure out whether there was some kind of delusional belief driving the decision, or whether in fact it was the person's own decision and just, related to sort of cultural factors or religious factors. And an example that was given was of an elderly patient who was refusing painkillers, and he was saying that this was for religious reasons, and he was in, he was suffering, he was in quite a bit of pain. And the doctors were really worried, and they thought, does he have a psychotic illness? Is that the reason why he's refusing? And is it some kind of a religious delusion? But the psychiatrist who saw the patient was able to sort of find out more about this person and, what their life history had been. And actually they'd been sort of staunchly religious throughout their life and had very strong sort of beliefs. And these had even intensified towards the end or as this person got older. And the psychiatrist even got a Catholic priest to come in and speak with the patient to sort of check whether this really was, a decision that was in keeping with his belief framework. And they felt that it was, and they felt that actually he did have capacity to refuse to accept painkillers for his pain. And the quote that's here is from a different case actually, but it's this idea that sometimes it can be really hard to actually pick out if there is a mental illness causing the decision, if there is a delusional belief, or actually if this person maybe just has a belief that's different from the psychiatrist's belief, but nonetheless very understandable in the context of their own history. And there were sort of various different illness factors that could be relevant, but this is just the example of a delusional belief, or a not a delusional belief, as this case turned out to be. So the second main theme was looking at difficulty in applying ethical principles. So kind of less clinical, this one. And the quote that you'll see there, it's sort of about the drive or the ethical duty to protect the person's welfare. And psychiatrists said that, they're more likely to be called where the stakes are really high, where it's a life and death decision. And in those cases, you really don't want to be casual about how you assess someone's ability to use and weigh, because you don't want to be too coercive, but then at the same time, you don't want to let their life slip away because you've made the wrong judgment. So psychiatrists here were really grappling with this idea that if the decision is very high risk, so if the patient is refusing a treatment that's life-saving, for example, does that change how they do the capacity assessment? And some felt that actually it should change in terms of the threshold for capacity, so that actually you should be, if the risks are high, you should have a higher threshold in terms of using weighing, so that the person really needs to be able to use and weigh the sort of nitty-gritty of these high risks. Whereas, you know, if the decision was a lower risk decision, that they wouldn't need the same sort of threshold of using weighing ability or the same threshold of understanding. So some psychiatrists felt that that was the case, you shifted the threshold, but others were really worried about this, and they felt, well, you know, given that we're supposed to presume capacity, is it fair to sort of put a higher burden of capacity on these people just because they're making a higher risk decision? And other people looked at it a bit differently. They said, well, maybe it's not the threshold that's shifting, but actually I need to find more evidence that this person has capacity, or less evidence that this person lacks capacity, or I need to do a more intensive assessment. I really need to work hard to make sure I'm getting things right or getting as accurate as possible in assessment. So there were sort of different ways, but people sort of differed and struggled and grappled with the ethical implications there. And the third theme, so again, sort of an ethical theme, was difficulty in avoiding personal bias. So psychiatrists really spoke quite candidly about the sort of personal drives that are the person, you know, the things that go through their mind when they're doing a hard capacity assessment. And they spoke about how difficult it can be sometimes to see a person who's making a decision that's going to let their, you know, their condition deteriorate. But they said it's also really difficult to see somebody be overruled and be subject to restrictive medical treatment, for example, you know, coerced to have medical treatment that they don't want. And they spoke really about the emotional toll that can have. They also spoke about even more personal factors, so feeling really worried that if their patient came to harm based on a decision that they took, that actually they could be criticised or they could be, you know, sued even, you know, if that were to happen. So some spoke about their own sort of political values and spoke about how, you know, they felt that they were a libertarian or they really valued autonomy, for example. And others kind of thought about, you know, the medical profession, and they sometimes contrasted the medical profession with social workers, and they wondered if medics were more likely to find somebody to lack capacity in a borderline case because of maybe, you know, this kind of caring instinct or wanting to do something, or maybe being more aware of, you know, untreated illness, what grisly consequences that can have. And psychiatrists were really open and sort of candid and reflective about the kind of biases that could come into play in difficult capacity assessments. And they were really sort of, you know, many of them showed a great awareness of, you know, the dangers of sort of applying their own values to the values of the person and saying, well, just because this person is making a decision that I wouldn't make, you know, according to my values, it doesn't mean that actually they lack capacity. And that's very much in keeping with the spirit of the MCA, which says, you know, people should be allowed to make unwise decisions. So psychiatrists really advocated of being sort of aware of one's own values to ensure that you don't impose them on somebody else in a capacity assessment. And finally, so this was again a more clinical area of difficulty. So in terms of the actual sort of procedure of the assessment itself. And one example that came up quite a bit was where the person didn't want to engage in the capacity assessment, and how this was really sort of difficult for the psychiatrist. And sometimes the person would engage with the assessment, but they'd only engage in a limited way. So there was one example of a person who, I think it was a patient who was suspected to have depression. He was refusing renal dialysis. And the psychiatrist was assessing him, and the person was saying yes, no, yes, and it was all sort of one-word answers, and the psychiatrist felt that the patient kind of knew exactly what he was trying to do in terms of assessing for depression, and just wasn't really interested in giving any information to the psychiatrist, and that was really difficult. And there were sort of other examples where the psychiatrist was really trying to grapple with whether the person wasn't engaging for their own reasons, or if actually they were unable to engage. And there was an example of a woman who had a very severe schizophrenia. She was quite thought disordered, and whereas superficially it might seem that she's just being dismissive, actually when the psychiatrist saw her repeatedly and sort of spoke with people who knew her, was able to figure out that actually this person really wasn't able to engage. They just had poverty of thought. They couldn't sort of grapple with the information. Their thinking processes were restricted because of the psychotic illness. So what psychiatrists really found helpful helpful in these cases was to work hard to build rapport. And sometimes that involved, you know, bringing somebody else in, somebody who the patient had a good relationship with, doing multiple assessments. And where it wasn't possible to engage the person at all, sometimes the capacity decision had to be made through observation, through involving other people. Yeah, so I guess just in summary, sort of the findings that we had, so the conclusions that we made were that you need both clinical skills and ethical skills in hard capacity assessments. We found that these sort of experienced assessors are aware of the kind of pitfalls that you can make, like sort of adhering to personal bias, for example, and that psychiatrists who do a lot of capacity assessments have developed lots of creative strategies to resolve hard cases, and we hope that they can be sort of, that summarizing those strategies can be useful for other people who are approaching hard capacity assessments. So that's sort of the interview study. I guess just briefly to mention from last year, so the court, so I published from one of the court studies, and there's been a second paper on that as well. And the court study also has contributed to capacity guidelines, which are available online. And as Claire said, I was lucky to be able to go to the National Institutes of Health in the States and to work in a bioethics department. That's a picture of me with the cherry blossoms behind me. And that was really, because I'm just so interested in mental health ethics, and it's really sort of at the core of my research. So it was great to get some different perspectives over there. And just again, the capacity guide. So this is a publicly available guide for clinicians or any social workers, anybody who's doing capacity assessments. And my research, my court research, fed into the part about understanding the functional criteria. But I'm also hoping that the interview work, you know, looking at specifically at hard capacity assessments in a medical setting and how people resolve them, I'm hoping that that will be sort of another section on this guide, which is going to be evolving. So thank you very much. Thank you so much to Mental Health Research UK, who've supported me over the past 4 years, to my supervisors and to the family of Tom Palmer. I think Judy's here today. Thanks so much. I mean, it's been great, and I'm a bit bittersweet to do my final Scholars Day, so much appreciated.
Thank you very much indeed, Nuala. That was so interesting, absolutely fascinating. And I think for me, seeing the outcomes of the work that you've done, and the capacity guide, and that the fact that that's going to be a kind of evolving resource, is just a really good example of how research can translate into something with real practical application. So absolutely great. Thank you. So are there any questions from anybody? Just in the last couple of minutes, are there any general questions that anybody would like to, are there any general questions about the MD Res and so on that anybody would like to hear more about? I mean, I guess that I will ask a question, and any of you can respond to this. I mean, it seems to me that that it is extremely demanding to do to carry out this research over a number of years while you have really demanding clinical commitments as well. And I just wondered if one of you would like to say something about that experience of balancing the research with your clinical commitment.
I can start. I'm sure others have things to say as well. So I was lucky in that I had a funded year to do my data collection. So that was on a larger project, but I think that was really helpful for me. I think the other thing that was really helpful is we're so lucky in psychiatry training to have a day a week to devote to a special interest. And in my case, that was research throughout my training, or my higher training at least. So that's how I've been managing to do it. And I think there's real benefits to doing research alongside your clinical work. So I think I know you spoke about sort of real world applicability. I think like that's what I want to see, you know, because I'm a clinician, and I'm keen to see like my work actually have impact in clinical practice, and I think you really maintain that drive and motivation by doing your clinical practice. But yeah, it's not easy is the other thing I'll say, and you certainly have to learn, and it's things I probably learned by making mistakes, but by trying to be sort of boundaried around your time, and trying not to take on too much and learning to say no and all those things. And I think those are things you learn by doing them completely wrong, and then sort of realizing that you can't do it that way, and you need to be more boundary, etc. So I don't know if others have similar experiences.
Camilla.
Yes, it's a really good question. I just like to also incorporate having two young children, and sort of taking maternity leave combined with that. So yeah, the three things. I think, yeah, it definitely is I think perhaps a struggle. And oh no, we're going to finish very soon. But that's why I've invested so much. I'm applying for this job as a consultant, where I've been talking to them, and they say that there's a possibility of basically me having 2 days research a week. And this is what I'm really going for at the moment, to really have those days set aside, where I can continue doing this research, on the same day, and it will be the same job and everything stays the same. And that stability, I think, will really help juggle the three things.
Thank you. Well, have you got one word to say, Kate, right at the end?
I think just, the future, I guess, is trying to find job plans where it's possible to do both, because I think it's very nourishing to be able, and helps with sustainability, to be able to have different things. So definitely. Yeah, anyone's out there thinking about consultant job plans, putting in time for these kind of things is great. They both feed off each other.
Just in the last couple of minutes, are there any general questions that anybody would like to are there any general questions about the MD Res and so on that anybody would like to hear more about? I mean, I guess that I will ask a question, and any of you can respond to this. I mean, it seems to me that that it is extremely demanding to do to carry out this research over a number of years, while you have really demanding clinical commitments as well. And I just wondered if one of you would like to say something about that experience of balancing the research with your clinical commitment.
I can start. I'm sure others have things to say as well. So I was lucky in that I had a funded year to do my data collection. So that was on a larger project, but I think that was really helpful for me. I think the other thing that was really helpful is we're so lucky in psychiatry training to have a day a week to devote to a special interest. And in my case, that was research throughout my training, or my higher training at least. So that's how I've been managing to do it. And I think there's real benefits to doing research alongside your clinical work. So I think I know you spoke about sort of real world applicability. I think that's what I want to see, because I'm a clinician, and I'm keen to see my work actually have impact in clinical practice. And I think you really maintain that drive and motivation by doing your clinical practice. But yeah, it's not easy is the other thing I'll say, and you certainly have to learn, and it's things I probably learned by making mistakes, but by trying to be sort of boundaried around your time, and trying not to take on too much, and learning to say no and all those things. And I think those are things you learn by doing them completely wrong, and then sort of realizing that you can't do it that way, and you need to be more boundaried, etc. So I don't know if others have similar experiences.
Camilla.
Yes, it's a really good question. I just like to also incorporate having two young children, and sort of taking maternity leave combined with that. So yeah, the three things. I think, yeah, it definitely is I think perhaps a struggle. And oh no, we're going to finish very soon. But that's why I've invested so much. I'm applying for this job as a consultant, where I've been talking to them, and they say that there's a possibility of basically me having 2 days research a week. And this is what I'm really going for at the moment, to really have those days set aside where I can continue doing this research, you know, on the same day, and it'll be the same job and everything stays the same. And that stability, I think, will really help juggle the three things.
Thank you. Well, have you got one word to say, Kate, right at the end?
I think just, yeah, the future, I guess, is trying to find job plans where it's possible to do both, because I think it's very nourishing to be able, and helps with sustainability, to be able to have different things. So
Definitely.
yeah, anyone's out there thinking about consultant job plans, putting in time for these kind of things is great. They both feed off each other.